Hello there, it's Luke. In this tutorial, we're going to be offering an overview of heart failure or congestive cardiac failure, as you might hear it referred to. We're going to consider some of the causes. We're going to look at how the disease progresses and how the body's normally very helpful neurohormonal compensation for low cardiac output is part of that. We can consider cardiac remodeling, and then we're going to look at classifying the disease, and in particular looking at ejection fraction as a means to do that. So we've got a definition here. Heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or reject blood. So it can be an issue with failing to fill the ventricle, or for a weakness of the ventricle being able to eject the blood out into the systemic circulation. And it's estimated that just under 1 million people in the UK are affected to some degree with heart failure. Now, in terms of being affected, there are different symptoms that can manifest with heart failure. So dyspnea, difficulty breathing. And if you can imagine, if your heart is failing, then you're going to get fluid collecting in the lungs and affecting your ability to breathe comfortably, and also affecting your oxygenation. And off the back of that, people have something called orthopnea, which is where they breathe better when they're upright or slightly leaning forward. Paroxysmal nocturnal dyspnea is a symptom whereby when somebody's laying flat, they have increased hydrostatic pressure and there's more fluid heading towards the thorax, and the ventricle, the left ventricle, is unable to cope with that, and so they have pulmonary edema when they're lying flat. And so these people go to bed, lie flat, and then wake up starving for breath and oxygen in the middle of the night. Very distressing symptom. They can have fatigue, as you can imagine, with a lower cardiac output state. If the heart failure, especially if it's affecting the right side of the heart as well, they may get ascites forming, sacral edema occurring at the ankle or the sort of lower leg. There can be chest pain. There can be a cough at night, and also if you imagine if your brain is failing to be perfused, then you might end up confused or feeling very tired, very lethargic. Now, the symptoms might be classified. Don't worry, I'm not going to read every little bit of this. Have been classified by the American College of Cardiology and the American Heart Association. And essentially, stage A is somebody who has risk factors for developing heart failure. Stage B is somebody who may have actual cardiac injury. Perhaps they've had a myocardial infarction, for instance, but is yet to demonstrate symptoms. Stage C is somebody who has both some heart injury and is demonstrating symptoms, and stage D is somebody who, despite maximal therapy, is still getting dyspnea and fatigue and all of the other symptoms that go along with heart failure, even at rest. Now, I'm going to offer this model for how heart failure begins and then progresses. So we start off with a myocardial injury or some sort of structural abnormality to the heart, and we'll go through some of those in just a moment. This reduces in a drop-off in cardiac output and stimulates a response of all the normal processes that we have to maintain cardiac output and maintain tissue perfusion, things like the baroreceptor response, things like the renin-angiotensin-aldosterone system. But in doing so, these place extra stress on the wall of the ventricle and bring about remodeling of the myocardium, which ultimately means that it works less effectively, either doesn't fill as well or it doesn't eject blood as well. Now, in terms of myocardial injury, a lot of cases of heart failure will stem from some infarction, so some coronary artery disease, the myocardium, but there can also be problems with the valves, and I'm talking principally about the aortic valve perhaps being stiffened, so aortic stenosis, or a regurgitant mitral valve. Untreated high blood pressure, so hypertension, will have an impact on stress on the ventricle, as will pathologies in other parts of the body. And if you can imagine, if you've got fibrotic changes in the lungs, or there's, say, a pulmonary embolism within the lungs, that's going to place pressure on the right side of the heart. Similarly, lifestyle factors such as too much salt in somebody's diet, excessive alcohol intake, cocaine certainly places a stress on the myocardium, can also impact and injure the heart as a starter for this process of heart failure. So the neurohormone responses, well, I've described these in detail elsewhere. However, we'll revisit them briefly here. So the baroreceptor reflex senses a decrease in the stretch in the aorta and carotid sinus, and that brings about a number of changes, one of which is an increased sympathetic autonomic stimulation of the vascular smooth muscle, which is increased further still by the release of adrenaline and noradrenaline from the adrenal gland, all of which will improve the systemic vascular resistance or increase the systemic vascular resistance, and in doing so will also improve preloads. It squeezes blood sort of away from the peripheries and the capacitance vessels. The renin-angiotensin-aldosterone system, well, there's a number of triggers for the release of renin and ultimately the production of angiotensin 2, which is a vasoconstrictor, so more increase in systemic vascular resistance there, and ultimately aldosterone being released from the adrenal cortex, which causes the nephron to reabsorb both sodium and therefore water, which will increase the preload. Now, what we haven't mentioned up until this point is the hypothalamus pituitary gland antidiuretic hormone system, and there are osmoreceptors within the hypothalamus that sense the concentration of the blood, and they sort of sense whether the blood is very concentrated with sort of with proteins and things like sodium, or whether there's sufficient water molecules and whether the blood is sufficiently dilute. And if in the context of somebody being dehydrated, the blood isn't sufficiently dilute, or there isn't a high enough concentration of water molecules, might be a better way of putting it, then it stimulates thirst, but it also stimulates the reabsorption of water from the kidneys. But also, antidiuretic hormone itself is otherwise known as vasopressin, which is a potent vasoconstrictor. So again, we've got an increase in preload and increase in systemic vascular resistance. And here we go. So going back to our model. So as I've just said, if we reabsorb more water, if we reabsorb more sodium, we get more preload. In a failing or injured heart, that puts more stress on the ventricle. And again, if we are increasing our smooth muscle tone in our blood vessels, we're increasing our afterload, or if we have a diseased aortic valve, which is very stiff, we're increasing our afterload, and this is again putting stress on the left ventricle. It's important to bear in mind that this can happen on the right side of the heart, but for the sake of this tutorial, we're focusing very much on the left ventricle. So here's our model again. You can see that it's a cycle. And as the heart becomes remodeled, we get a reduction in cardiac output and the stimulation of that neurohormonal response, and we go around in circles. So what do we mean by myocardial remodeling? Well, there are many mediators will be involved. There'll be inflammation, there'll be a lot of the usual suspects, so tissue necrosis factors, there'll be growth factors released that ultimately lead to either the heart becoming dilated, so it almost takes on a sort of globular form and sort of thinned out, and you have layering down of connective tissue rather than sort of replacing heart muscle cells, and it becomes less effective at contracting well and ejecting blood into the systemic circulation, and we would refer to this as systolic heart failure. Now, the heart can get dilated to the point where the annulus, which is the bit that holds the mitral valve, gets stretched, and so the mitral valve doesn't close properly, and you can have something called mitral regurgitation. And here is an X-ray of somebody with cardiomegaly, so a dilated heart, and you can see it's taking up a huge volume inside this chest. It doesn't take anywhere near this size, and this would be the appearance on a chest X-ray. There's another type of remodeling that can occur where the heart becomes hypertrophied, So you get a layering of extra muscle and fibrous tissue. So you get this very thickened heart muscle that it becomes increasingly stiff, and so it's difficult to refill the heart with blood because you've got poorly compliant, stiff ventricle, and you might experience diastolic heart failure, so the failure of filling of the heart. And both of these things can occur at the same time. So one way of quantifying heart failure is to do transthoracic echocardiogram, ultrasound, to look at the function of the heart. And what we're looking at is ejection fraction. Now I'm going to show you the pressure volume curve here as a bit of revision. So at point A, the mitral valve opens, we have passive filling of the left ventricle until we have contraction where the mitral valve closes. We get a big jump up in pressure until it's sufficient to open the aortic valve at point C, and then get ejection of blood into systemic circulation and a drop off in pressure before the aortic valve closes, and a further drop off in pressure before we open the mitral valve again and we start passive filling. And I'd just like to highlight the LVEDVs, the left ventricular end diastolic volume, which is the point where the heart is at its fullest immediately before it contracts. And the left ventricular end systolic volume is the point where there's a little bit of blood left in after the heart has contracted, and there's just a tiny bit of blood left in there. And of course the stroke volume is the difference between those two. Now the ejection fraction is a percentage given by the stroke volume divided by the left ventricular end diastolic volume times 100. And a healthy ejection fraction would be about 70%. So thinking about patients with heart failure, perhaps with symptomatic heart failure, they might have what we call a preserved ejection fraction, where they're ejecting 50 to 70% of the left ventricular end diastolic volume on systole, but still might be experiencing symptoms. And these would be the people with that hypertrophied, thickened heart muscle that was beating, that wasn't filling well. Conversely, you might have heart failure with reduced ejection fraction, where you've got this big dilated heart, it's unable to contract efficiently, and consequently you're getting less than 40% of the left ventricular end diastolic volume ejected with each systole. And in this instance, if we think again about the Frank-Starling relationship, so for an increase in volume, you would expect an increase in both the force of contraction, so the contractility, and the stroke volume. And in a healthy heart, the more volume we give somebody, you see a positive change in terms of the force of contraction and the stroke volume. In a sort of weakened, dilated, failing heart, you might be adding volume, so you might be either sort of neurohormonal response or giving a fluid bolus, and that heart is unable to cope with that, so you don't see the corresponding improvement in the force of contraction or the stroke volume. And even to the point where, say, you give this person a fluid bolus and they're unable to handle that, and the heart beats even less effectively. Thinking very quickly about the that pressure volume curve we were just talking about, so with a reduced ejection fraction, we're unable to generate the force of contraction, and so consequently there's less blood ejected and we have more blood remaining within the ventricle at the end of systole. The converse of this is heart failure with preserved ejection fraction, whereby, as I said, you've got this hypertrophied, stiff ventricle and you can see on this diagram we've got heightened filling pressures, and because we're not able to get in the same amount of volume during filling, that will have impact on contraction of the ventricle, and so we're going to get a smaller stroke volume. We're going to have less contractile force and less cardiac output. So in summary, heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. Neurohormonal responses including the baroreceptor reflex, the renin-angiotensin aldosterone system, and the antidiuretic vasopressin release, whilst attempting to maintain cardiac output, will actually worsen injury and cause further remodeling of the heart, and we get stuck in this cycle where heart failure progressively gets worse over time. Thank you very much for listening.